I would also like to thank the Greater New York Meeting for sponsoring such a lovely meeting. It's great to get together and share ideas. Often we learn more from the person we sit next to than some of the courses, so I'm very happy that you're here. I'm also happy because spreading the word of oral health is something that I'm very passionate about. I've been a periodontist since 1990, and that was before the implants became such a big deal. So I went into periodontics to help people save their teeth, and I'm still very passionate about that. Thanks to my Millennium Dental Technologies team, and I couldn't be here without them. They really are very supportive and a very well-run organization, so it's a pleasure to be part of that. So today, I feel very glad because I've gone from one beautiful skyline to another. So these two photos are some of the loveliest cities that I think the world has to offer, Chicago and New York. And I've looked at a few of the presentations as I walked by during the meeting, and I've noticed that a lot of them are very specific to this is what you can do. As soon as you leave here, you can do this. Unfortunately, for this procedure, this is just for demonstration purposes only. It's very important that we keep in mind not to do any harm to our patients. And because of this laser technology and the way it's paired with such significant training, this is not something that I'm advising you to take home and do today. So I am just doing this for demonstration purposes only. There are many lasers that are available, and they each have a specific use. They're hard tissue lasers, say your erbium lasers, which are really great for cutting bones, dentin, enamel. And then there are your soft tissue lasers. And this particular laser was specifically made for this technique. And the training that is involved with this technique is very specific also. It's a very specific protocol, and it's essential for the safety of the patient, the safety of the staff, and the safety of the doctor. So that's something to really keep in mind. The protocol that I'll be doing today is known as laser-assisted new attachment, and that stands, and so it's called LANAP. It's also called laser-assisted regeneration. And the reason that we can say this is because of the clearance that we've received from the Food and Drug Administration. It's like a marriage. The steps of the protocol and this laser, they go together, and they can't be divorced. They can never separate. You can't use another laser with these steps and have confidence that you're going to get this regenerative approach to helping our patients keep their teeth. So that's something to just keep in mind. The LANAP protocol is very specific, and it can only be done with this periolase. And this is the laser that I have at my office in Chicago. It's my best friend when it comes to helping my patients manage their chronic infection of any stage, early to late, early gingivitis to aggressive periodontitis. The interesting part about this protocol is it was started on hopeless teeth. Two general dentists who tinkered with lasers, all different types, came across this through experimentation and developed this laser and made it specifically for helping us manage those highly important health conditions known as the periodontal diseases. And these are the steps of the procedure. You have initially to get local anesthetic, and my patient, Mr. Senor, has already been given his local before you all arrived, and my assistant, Veronica, has been kind enough to get him all ready for me. So he's just sitting back, relaxing. We've already done the probings, and that's kind of the initial step. You want to check and make sure your patient's numb, and you want to sound to bone type probings. The laser energy coming out of this periolase fiber is 1064 nanometers, and that laser energy is initially used in a specific setting to remove the epithelial lining of the pocket wall. So that's the second step of the LANAP protocol. And that begins the initial opening up of a small flap. After that, initial removal of that epithelial lining, which exposes the underlying connective tissue. Then you use your EMS tips to do a really good scaling and root planing, but not like we would do with our hand instruments. It's kind of counterintuitive, but with this, we're not degranulating the pocket, and that's something that's really quite different. I spent many years degranulating pockets, open flap, getting down to that bone. This is not that procedure. So you want to keep all of the connective tissue, and so these EMS tips are really good with that. So you do a very good scaling and root planing, and then you continue your dissection down to bone with your final EMS tip. Up until this time, the procedure is relatively clear and not too much bleeding. But once you go down with that second setting of the laser, you create a nice hemostatic clot because you created some bleeding when you go in to do that blunt dissection. In order to maintain that clot stability, we want to make sure that any occlusal trauma is minimized as best as possible, and so we do an occlusal adjustment. This is all done in one visit, so you no longer are taking your patient through initial scaling and root planing and then waiting 6 weeks and then going into another procedure. So now we have the ability to, in one session, get our patients from an extremely high level of infection and escort them into a regenerative phase of healing. And it's because we're using the basic principles of wound healing. We're clearing out the infection because this laser energy has been shown to kill off the bacteria very effectively. We've gotten rid of the epithelium, which is kind of the basis of guided tissue regeneration, and we've exposed that connective tissue. And then we blocked out the epithelium from growing back down into the pocket wall by creating this nice fibrin clot at the time of the procedure. So we've kind of accelerated the healing initially. So it's important that we, as clinicians, practice evidence-based dentistry. But the thing about evidence-based dentistry is that it requires certain factors, and I'll get to that later. But what I wanted to point out is the huge difference between aesthetic dentistry and a lot of the dentistry that we do day to day and periodontal therapy. As I said, I've kind of been watching some of the lectures that have been going on, and with aesthetic dentistry, you have a very narrow margin of error. Your patients hold in the mirror really close. A millimeter difference makes a big difference. The shading is so important. You can't vary outside of that margin. But when it comes to periodontal therapy, that's an ongoing relationship with the patient throughout their life, and we're supporting them during that time. And so there's this wide margin of error or correctness, and you have to really decide what your standard of care is going to be. So what makes me so happy as a periodontist and someone who's so dedicated to oral health in a community that has such a high health issues, that now we have this one visit or 2 visits where you can really increase the level of health and kind of narrow that margin with this periodontal therapy. Excuse me, I just need to take a little sip here of water. So there's 3 components to evidence-based dentistry. You need to have good research, you need to have the patient to accept the treatment, and you need to be able to perform the procedure. So it's right in that little sweet spot that it all kind of comes together. And that's something that we have to keep in mind. We can easily just hear that something works well and try it, but if we don't have some scientific evidence, it may not be a good idea. We can have a whole lot of research, but if the patient doesn't accept the treatment, then we can't practice it. Or if we have a procedure that's very difficult, we may not be able to do that procedure even though the patient may want it. My husband's in the audience. He's an oral and maxillofacial surgeon, and I've kind of been watching him for years with all of these lovely surgeries that he does, but it takes a lot of dedication, a lot of effort to learn to be at that level. When you can get a procedure that does have the clinical evidence, that can be done because the training is so specific and so useful, and the learning curve is not that steep, and the patient acceptance is so good, then it really is a sweet spot when it comes to it. And the LANAP protocol is that for me. So what I'd like to do is just quickly go over the histologic evidence and just show some of the data from my practice that shows why this has worked so well. Histology was kind of my passion, so when this research came out, it was pretty quick for me to make the decision to make this purchase. Because if I have human histology that shows a long junctional epithelium for scaling and root planing, but with this procedure, I see new attachment, which means cementum, periodontal ligament, reattached to a previously diseased root, in the absence of long junctional epithelium, I'm personally very happy. Now, I realize my patient really doesn't care about that. So often patients care about two main things, right? Is it gonna hurt? How much does it cost? Or is the bleeding gonna stop? But from my perspective, if I know that I can elevate their level of health and regenerate what's been lost without doing a significant invasive surgery, I'm pretty good with that. So as soon as I saw this study, I was like, where do I sign up? It was very easy for me. So this is just some of the histology that the FDA used to give the clearance for new attachment. And it basically shows the new bone, new cementum, and the level of the junctional epithelium being above that. So again, this is just human histology where Dr. Yetta had 6 teeth, 6 patients, 2 teeth per patient. 1 tooth he did the LANAP protocol on, 1 tooth he just did scaling and root planing. 3 months later, took a block section and did the histologic study. Very straightforward, very simple. And all of the 6 teeth that had the LANAP protocol, you saw new attachment. Simple, beautiful study. And then that was followed up with a second human histologic study by Dr. Nevins. And again, some lovely histology that came from that. So those are 2 human histology studies that show the scientific evidence that supports new attachment. And now we even have the designation of true regeneration, basically regeneration of bone. So bone, cementum, periodontal ligament, regrowing on a previously diseased root. And keep in mind, this was started on hopeless teeth. So this, again, this is just some of the histology that shows that. And then another very nicely designed study that points to how it kills off the bacteria. Beautiful design. Paper point microbial sampling before scaling and root planing and before LANAP, and then paper point microbial sampling after those 2 procedures. Very simple. After scaling and root planing, you could still culture the bacteria. After the LANAP procedure, you could not culture the bacteria. So again, scientific evidence that shows that the bacterial count is so low after using this laser energy that you cannot culture the bacteria after the procedure. So this is certainly much more effective than just plain scaling and root planing. And again, it points to the rationale of wound healing. You can't have an infected wound that will heal. It just won't heal. But if you clean out the infection, then the body's own healing abilities come right in and take care of it. And then there's also empirical evidence, case study after case study, that shows this regeneration. This is one of the cases that the founder of the company, Dr. Bob Gregg, did, and this is a 6-year follow-up. And then this is another tooth. Again, this was started on hopeless teeth. So this kind of tends to change the way you treat a patient. Instead of extracting teeth on the front end of a treatment plan, you now wait to see what the body is going to deliver for you, and then you can make a clinical decision. And if a patient has a choice of keeping the tooth or not keeping a tooth, they're usually going to choose to keep their tooth. If they have a choice of flap surgery or the LANAP procedure, they're likely going to choose the LANAP approach. So this is a case, one of my first cases, where I had a young lady, aggressive periodontitis, localized aggressive periodontitis, which I hadn't treated her, but I had treated cases before, which turned out very well, but it was with the M to gain, the growth factors, the membranes, and got regeneration. But just using this LANAP protocol, I was able to get some really nice results for this young lady who was able to keep playing volleyball after the procedure, didn't miss a beat, didn't have a traumatic experience to base her future dental care on. So it really has been a great addition. And then when it comes to patient acceptance, in my practice on the south side of Chicago, and I'm sure we all share in this experience, where we have patients that are throughout the spectrum of health, young, healthy individuals, middle-aged to older. And we see as life happens, disease can encroach upon people's lives. And so how we can help them manage and keep their teeth for a lifetime, that's the question that we have as dentists. And a couple of people have asked at the booth, well, how do you know it's working? How do you know this is successful? And I thought about it because now I have patients. I've been in practice for about 30 years, and sometimes we'll call and they've made the transition. They're no longer with us, but I've helped them keep their teeth a lifetime. So for me, that's how I measure success in certain cases. That patient that had advanced periodontal disease, they kept their teeth their whole life. Now, you can also measure success by 50% pocket reduction, which is something that we do say you'll get. You can measure success by reduction in bleeding and bleeding with probing, but you just have to think of what you consider success. So when you have patients that are in a variety of socioeconomic strata, it's nice to be able to offer something that people can accept and can afford. So when it comes to case acceptance, like I said, if you can keep a tooth, you're better off. I also do this procedure around ailing, failing implants, because sometimes you get patients after the fact where their teeth have been removed and implants are in place, and people that are at risk for periodontal disease are also going to be at risk for peri-implantitis. So you want to make sure that they understand that maintenance is always essential, so this can come into play for helping ailing implants also, and that's a procedure known as LAPIP. But these are just some of the stats from my office where basically because I had so many patients that hadn't accepted surgical care, that once I started doing the LANAP protocol, my case acceptance really doubled or tripled even in some cases. So when it comes to this procedure, it really does allow us to practice evidence-based dentistry, and training is very essential. And so there's the boot camp. Mr. Senor, our patient, was kind enough to be our boot camp patient, so he had the first half, the right side, treated earlier this month, and today we're going to finish today treating the left side with the LANAP protocol. The boot camp is a year's worth of training, 3 days, 6 months later, another training on a live patient, and then 6 months after that. So you really do leave knowing how to do these steps. And this is the patient we're about to see today, Mr. Senor. This is his Panorex, and then here are his probing depths. I have a few slides to show you so you can kind of get a feel for how this procedure looks about 18 hours after. These are from the boot camp that was just done recently. So this is the quadrant that we'll be working on. There's some recession, not a lot of local factors. He doesn't have a lot of heavy calculus, but still he does have evidence of significant loss of bone. He's okay with me discussing his medical history. Basically, he's had a history of a kidney transplant and a history of epilepsy. So he is on some anti-rejection medications, anti-seizure medications, but fortunately, we don't see the gingival hyperplasia that we sometimes see with the dilantin. But still, there is evidence of some inflammation. This is a picture of 18 hours, and you can kind of see that residual fibrin clot at the margin of the tissue. No open flap, no sutures, but still a really closed flap. And this is 18 hours after the LANAP procedure is done. Patient comfort is pretty good after the LANAP protocol. We also have the ability of this biostimulation that tends, low-level light therapy, biomodulation. This laser wavelength also affords that, so it can help with post-op pain, arthritic pain, all kinds of other add-ons that this laser can do for you. Minimal swelling because, again, we're not reflecting a full flap. This is a little fuzzy here. But pretty much now, that's my intro to what I'm about to sit down and do. And after I'm done, I'd be happy to take questions. And if time allows, I have some of my cases that I always like showing that kind of shows how I was able to reach into the community and reach even beyond my community because of being able to offer such a minimally invasive yet very effective regenerative surgical procedure to help patients hold on to those precious teeth and keep a very high level of health. You know, lower their risk for heart attack, stroke, all of these periosystemic links that are becoming stronger and stronger when we deal with helping our patients stay healthy. So join me in my office and we'll get started. Oh, and I want to give a shout out to Oroscoptic. They're really great loops and they allowed me to use some inserts for laser safety. That's always important. So you notice that we are all going to have laser protection and I won't shine the laser your way, so you're protected too. I always wear my little bonnet, so. You know, our creature comforts at home, right? Okay. How are you doing, Mr. Senor? You can't talk, sorry. Isn't that a bad habit we have of talking to our patients when they can't answer? From there, thank you. And then if you would take it back. A little lower. Oh. I practice talking while I work. I usually don't, but I was practicing while I was in Chicago, and my assistant and the patient really liked it. So I said, oh, maybe I should talk while I work, kind of get in the habit of going over all of the things that I'm doing. So basically, I'm turning on my laser now, checking my fiber, using my power meter to make sure that the energy that it says it's putting out is being put out. Okay, I gotta do a little bit of cleave here. So your fiber is kind of like your blade, and you want to keep it sharp. So we've got these little cleaving instruments that are considered sharps. So we always want to put those in a safe place. Cleaving is kind of like the perfect golf swing. I've just started that sport and I'm beginning to see how frustrating that can be, but when you get it right, it's just perfect. Okay. All right, we're good. So I'm going to begin in the anteriors just so you have a good view of things. Like I said, that first entry, you're just removing the epithelial lining of the pocket wall. Oops, sorry. All right, and we can see where after The post-ops after the procedure is very light brushing and the Paradex mouth rinse. So we tend to get a little plaquey, but that's okay. We always want to use a nice high vacuum suction. And as you see, I'm just kind of gently going in and removing that epithelial lining. So a lot of surgeries are kind of exciting to watch because you're getting all down into the bone and reflecting this big flap, but this is not that type of procedure. The laser energy is what's doing the work for you. So you're really, it's counterintuitive in a way. You always want to do a little bit more oftentimes, but with the laser, less is better because this energy is selectively absorbed. So where there's inflammation, it's going to be absorbed more effectively. Where the tissue is healthy, it's not going to be absorbed so much. So you just kind of keep moving along because you don't want to linger too much. It's kind of like being out in the sunshine too long and you don't know you're burned until the next day. So you just want to easily move this around. Now you'll notice if I get close to this amalgam, you might get a little popping because this laser energy likes dark pigment. So you see it takes off a little bit of that amalgam. And you kind of heard that little bit of popping sound. So I always tell my patient, don't be shocked if you just hear this loud pop. I might jump out the chair a little bit. I'm never ready for it. So then we want to go back and make sure we're going to the accessible depth of the pocket. Picking up the papilla. And I'm the type that stands up and moves all around my patient. Okay? Are we seeing all right? Yeah, you might not be able to see too much as I'm going along the distal, but hopefully as I come around the lingual, you can start seeing a little better. And Mr. Senor has a lovely mouth to work in. My father was a dentist, and he would call this a noble mouth. Just nice and open. Now here we've got some deep probing depth, so you want to be careful not to have fiber breakage, so you've got to always have it a little bit extra extended outside of the pocket wall. Like I said, it's a pretty quick procedure. In a case like this, where there's not a lot of local factors, I'm sure it will be done before, the allotted time. If there are a lot of local factors and you're going to spend a lot of time scaling and root planing, you just kind of have to plan accordingly. But here I'm just going down to the accessible depth again of the pocket. There's that popping sound from that big old lovely amalgam. Let's bend this cannula a little bit. And so that's pretty much the first pass. And as you can see, minimal, if any, bleeding because of that laser energy just taking off that epithelial lining, but it's not really causing a lot of bleeding, which is what we expect at that first. So you have a pretty clear field. And then with the loops, you can see very well. Okay, we got a good cleave there. Just gonna get this out the way a bit so I can get behind him. I'm just going to start on this palatal. I like to start where I know I have the deeper probing depths, where my cleave is really good and fresh. And he's got some deep pockets more toward the palatal. And the local anesthetic generally works exceptionally well for this procedure. Sometimes if there's a lot of occlusal trauma on a patient, they might still have sensitivity, even with good local. But for the most part, I don't have to do a lot of sedations. Something about laser puts people at ease, and they're just a little less anxious about the whole idea of it. So you're able to reach into that phobic population and kind of get them through the threshold of comprehensive dental care, which is really important. You know, a lot of times we see patients that have kind of constantly been to the dentist and moved from one dentist to another, but that patient that hasn't been seen for quite some time, that's the one that this works so beautifully on, that's never had treatment. It works on everybody, but that real highly inflamed case, that's the one that you no longer dread working on. So Mr. Senor is doing great here. We're moving right along.
To Dr. Al Panjali.
Say that again. Can you take that mouth prop out so he can close a little bit? Close down a little bit, please. Thank you. You can turn away from me. This obturator is beautiful because you always want to make sure, again, first do no harm. So protecting the other areas just in case a fiber breaks and the energy comes out where you don't want it to. It's always important to protect those sites that aren't actually part of the surgery. And the distal molars is still a difficult area. I don't care what you're doing. So sometimes you got to bend your cannula a little bit to really get in there right. We okay? Turn away from me a little bit. Mm-hmm. There's not too much probing here, but on the other premolar there was. So I'm thinking that once I do the occlusal adjustment, I'm going to see one of these premolars is getting hit a little harder than the other. They're right in here. And you see he already has some recession, so we certainly don't want to increase that. It's not the type of case where connective tissue grafting is going to work too well because there's so much interproximal bone loss too. But he's got a nice amount of keratinized tissue, so he's going to be fine in that respect. So as you see, things kind of move along pretty quickly. There's a nice deep pocket there, just kind of went in there that one time. And that's the first pass. So second, we're going to start with the EMS scaling. So this is where we kind of go from dry to wet. And since Mr. Senor's had this done before, he kind of knows what to expect. But I always let patients know to kind of be prepared. Suction's going to change a bit. And this is where the loops come in real handy. Because now you do kind of want to see what's going on. So we're just using the P-tip first. And you can kind of see how we've gotten some loosening of this tissue. And you can really see how selective this laser is. If you look
closely, you can just see where that epithelium is just peeled away, and you see that underlying connective tissue. Suction right here on the facial, right where my tip is. Yeah, you can see that. I don't know how close the camera can get, but that just shows this selectivity of this energy. I love seeing that. I never get tired of seeing that kind of stuff. So you imagine that on the inside of the pocket also, because that's what's happened. And again, we've got histology that shows that from one of the first LANAPers, first histologic studies by Dr. Velarde. Again, I'm going to stand up. Hope I don't block the camera. And like I said, he doesn't have a whole lot of calculus. So this is going to go kind of quickly also. And I'm pretty much going down to bone. I'm feeling all the way to the bottom of this pocket. And as I'm looking, I can see into this pocket. I'm visualizing the root surface pretty far down. Now on the upper, where there's like a 8 or 9 millimeter probe in depth, that's going to be a little more difficult. But with these glasses I've got, I can go from 3 to 5 magnification. So that's where it's really helpful when you want to make sure you're getting this calculus off the teeth as best as possible. We've got study after study that shows you never get all of the calculus off the roots of the teeth, but certainly you want to give it as good a shot as you can get. So the more you can see, the better. And oftentimes post-op, you'll see it right at the CEJ. It's not even at the depth, but it's hugging at that CEJ. But there's a bulb tip that comes that I'll be using next that's designed for that part of the tooth. This is pretty much the use of the EMS. I used the Cavitron for the longest time until I started doing this, and now this is my favorite. So I'm going to turn up my magnification a bit so I can just kind of check and see how well this is going. And then if you could suction right here for me, right in there. Yeah. So I can just see this little ring of calculus. And then I also use gauze when I'm scaling and root planing to kind of distend the flap a little bit more, so I can really see. So for a brief moment, it's going to just be wide open for me, and I can just see right in there. And I can see that calculus, that pesky calculus that doesn't want to go. And suction. The assistant is so important. And you realize that when you have to be the assistant. And at boot camp, we end up being each other's assistants. So by the end of boot camp, you want to give your assistant flowers. And now you're starting to see some bleeding, which we expect now. So this is pretty much going along pretty well. Now, just because I just can't stand seeing this over here, I know he's not numb here, but I'm just going to lightly debride this a bit. You don't want to go subgingival after the LANAP protocol, but you can do supragingival plaque and calc tartar removal. And that's pretty much the follow-up. The follow-up to LANAP is very easy. Slight occlusal adjustments, little supragingival debridement, and basically they're in maintenance after. So it really allows you to get through the periodontal phase of therapy so much more quickly and so much more effectively, and get them ready for the next phase. Like, I'll send patients for orthodontics as soon as I know that that active inflammation has settled in and is no longer as active. So I'm not waiting all that time. So now I'm going to this next tip, which is just a little round ball. This was kind of designed for endodontic removal of the roof. So you got to be very careful again not to do any harm. So you move this along very quickly. But it's designed to get into your furcations, hugging at the CEJ. It really gets in there very effectively. Overhanging margins. A lot of times that's part of the problem with periodontal disease. It may not be that whole systemic problem, but it might just be that iatrogenic one where you've got prosthetics and restorations that are just adding to the significant contributing factors, we'll say. And again, I just want to check this real deep one just to see if I'm getting it right. Yeah, see, I can still see that stuff right here. Sorry. And again, I'm kind of feeling all the way down to the base of the pocket, loosening things up with each tip. Magnification helps significantly with this. It's not required, but it certainly is helpful. I know some excellent clinicians that don't wear loupes, but I've been wearing loupes for a number of years now. Doing all right, Miss Veronica? I'm just checking with my assistant. You doing okay? All right, good. And I always ask my assistant if they're seeing things I'm not seeing, because they've got a whole different perspective. So Veronica, how are we doing? You see any calculus I missed? No? Okay, thank you. My assistant in Chicago is Margaret. We've been working together forever. So she always says, Dr. Yetta, right there on that lingual, right there, gotta get that. Okay, so this is the last tip, and this is the one where you start doing more of the dissection all the way down to bone. So here's where sometimes I have to re-up my local. Are you doing okay, Mr. Senor? Okay. Sometimes I have to give more local here because I'm really getting in here now and touching all the way to the base of the pocket, stimulating that bone, scratching that bone a bit. Still removing deposits. And so now I want you to kind of back off with your suction. because I kind of want this blood to start pooling into that pocket so that when I come back with my next setting, I've got something to work with. So now we'll just kind of use the saliva ejector to remove the water, but no more serious suction. And sometimes you fall into pockets that you may not have even felt when you did your sound to bone probings. So this is a very effective stage of the procedure. Because whatever little bit of clinical attachment there was, you're breaking through it now. Now, if he had a real thin periodontium without a lot of keratinized tissue, I might handle this a little differently. So you just gotta let the tissue be your guide. You wouldn't want to strip through just some alveolar mucosa here. But here I can kind of feel into his furcation, down deep into this area here. Okay, so that's the end of that phase. And so now we're going to change the settings and go back for that final pass. Okay. Oh, the kids are having a good time, aren't they? They're brushing and flossing and doing all kinds of good stuff over there. So I got a good cleave, just gonna double check it here. Beautiful, okay. So this time you're gonna really go all the way down to bone. The first time you didn't quite get that far, but now you're going to create this nice thermal clot. So even though you're tempted to get them all cleaned up, you want that bit of bleeding to be there. You're going to get a little bubbling, as you see. That's that heat and the vibration creating those bubbles. A little acoustic effect from this laser. This is a real fun part, because a lot of the other part is just, you don't really get that tactile feedback you're used to getting as a dentist, where you're cutting something or elevating something. So this, you're getting your tactile feedback down the bone. And this is where it's really important to keep in mind not to do this with any other laser, because you are really laying in some energy now. Down the bone. And you sweep. Yeah, did you take that out? Okay, close down for me, please. Coming to the distal, again, this distal molar, right in there, great. In small mouths, third molars, this can be a very difficult part. Here in the front. Again, in certain areas you don't want to deliver too much energy. You want to maintain the papilla. All us periodontists love our papilla. So he's really got deep probings between those two molars. So the next step is to do the occlusal adjustment. So you do finger pressure to kind of close in. His flaps really, if he had been more edematous, we would have had a lot larger, wider clot. And this finger pressure, you would have just seen that flap come together. But his tissue's not as edematous as some others. So, but you get the idea. You want to get it tight. Okay, now bite down for me, please. Close down all the way. This is always the fun part. Bite down all the way. Close down. Put your back teeth together. Okay, put the tip of your tongue way back on the roof of your mouth. Close down. Mr. Senor, close down. Bite all the way. Close your teeth together. There you go. Open. Put the tip of your tongue way back on the roof of your mouth. And close down. Bite down all the way. There you go. That's what I need. Stay like that. And tap your teeth together. Tap, tap, tap. So you can see the movement here. Tap, tap, tap. Lots of fremitus on this front tooth. Tap, tap, tap again. And with your teeth together, grind from side to side. So you can see this is really a lot of occlusal trauma on the front. So you know your adjustment can do a certain amount, but he would really be a case where you would want to get a night guard or something to really protect that bite. But we're going to do what we can to help, just so this initial healing can be as effective as possible. So now we're moving into that occlusal adjustment step. So we want to keep the mouth as dry as possible. Alrighty, sir, let's close down again, please. Open. Close down. Tap, tap, tap. On your back teeth. Oh, there you go. Tap, tap, tap. And grind, grind, grind like an alligator. There you go. Tap, tap, tap. Alright, perfect. Thanks. Close down again. All the way in the back. There you go. Tap, tap, tap. Okay. Oh no, I cannot. So first I'm going to go where it's the most obvious, most severely involved, which is at front tooth. And you're not going to get it all completely done in one setting, but you want to at least get them on the right path. And you can kind of see how this lower incisor is a little more labial than the others. So we're definitely going to be taking this down a bit. Close down for me, please. Close down all the way. Tap, tap, tap. Open. Close down. Tap, tap, tap. Tap, 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 tap. Okay, open. Close down again. Open. Oh, good. We're good. Sometimes the occlusal adjustment can take as long as the rest of the procedure. But it's a very important component. Close down, tap, tap, open. Close down, tap, 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 grind, 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 open. So the mobility is something that we know we're going to just have to deal with. These teeth are probably never going to be solid again unless we go into this prosthetic phase with some permanent type prosthetic splinting. But splinting is a large part of LANAP therapy, and he would be a candidate that I would consider doing a temporary type rib-on splinting on, just to give us some stability during the healing. Close down for me, please. Tap, tap. Just to help out as a temporary measure so those initial healing phases can be more successful. So he will be followed up by one of our LANAP trained dentists, and I think that's going to be part of his treatment plan. If not, I'll suggest it because I think it'll be very helpful. They're not the prettiest thing in the world, but they really are helpful for helping people get more stability and potentially stop the mobility. Close down for me, please. Tap, tap. Tap, tap. Open. Close down. Tap, tap. Tap, tap. Okay, so we're a little better. Not a lot, though. Open. Close down. Tappy, tap, tap. And grindy, grind, grind. Open. Close down, tap, tap, open. So we're doing better on the central, now the laterals taking the hit, so we'll help that out a little bit. But for him, I'm mainly concerned about his anteriors. Close down. Tap, tap. Yeah, so that's better there. Tap, tap. And grind a little bit from side to side. Open. Close down. Tap, tap. And grind a little bit. Open. Close down. Tap, tap. Open. Close down. Tap, tap. Open. Basically, it's Gab's rule here, grind off loose spots. We're not doing a fine equilibration. We're just trying to get them through this initial phase of healing. Close down. Tap, tap. Open. Close down. Tap, tap. Open. Okay, so like I said, this is kind of for demonstration purposes only. I could get carried away with the occlusal adjustment and spend the whole rest of our time together with this. Close down for me. Tap, tap. But I think you get the general idea of what I'm talking about. So I'm just going to stop right here. Thank you so much, Mr. Senor. And then Veronica is going to take it from here and get him all ready and go over his post-ops. So that's pretty much the LANAP protocol in all of its steps, kind of an overview. And so now if anybody has any questions for me, I'd be happy to entertain those. Are there any questions? I'm sorry, say that again. Oh, implants, you follow the same steps, but you're trained about the amount of energy that you deliver and the increments you deliver the energy in because you have a dark body that's really highly absorptive. It's metal, that's titanium. So you just have to step back a little bit, but the steps are pretty much the same. The infusion adjustment, the first pass, second pass, scaling and replaning, all of those steps are the same. Any other questions? Say that again. Well, this is a 1064 nanometers. Yeah, well, that's kind of the secret sauce. So I'm not going to be able to tell you the actual pulse durations, what have you. That kind of comes along with the training, though. But the energy level, the wavelength is 1064 nanometers. It's a neodymium yttrium aluminum garnet laser. So the laser energy is at 1064 nanometers.
Are there studies that will culture the bacteria?
Yes, this study did culture the bacteria later, but I don't have that exact data in my brain. But that data is available. If you come by our booth, we'll be able to give you that information. But it was at a much lower level, even with time.
We have a question right here.
Do you follow after treatment with any type of rays such as Peridex?
Just a routine antimicrobial, Peridex or Listerine. Yeah, Peridex is considered part of a post-op. Peridex, soft diet. keep that occlusal trauma down.
What home care instructions do you give to the patient, and how long do you wait to probe?
Oh, you wait at least 6 to 9 months to really do a serious probing. And basically the patient's on a soft diet. Similar post-op instructions to any surgical procedure. Very similar post-op instructions. Soft diet, don't vigorously brush the area. You want to maintain that clot. You don't want that clot to be disturbed.
Why did we start the first step of the laser before the escape?
Well, you get better access, you get a little bit of opening up of the flap, and you have better control of bleeding. And again, doctors Greg and McCarthy, they just kind of tried it all kinds of different ways and have come up with the best way. They've tried it, mixing up the steps all together, but these steps seem to be the most concise, rational way of getting it done efficiently and effectively. Oh, how often is it necessary to do this therapy in 1 year? I've seldom had to retreat in a year. It depends on the patient though. So I use, on this patient, oh yeah, you may not ever have to use it again. This is a one-time treatment. But if they start showing breakdown, inflammation, probing depths change, bone loss comes, then you would want to retreat just like with any periodontal regimen you follow. Contraindications for the treatment? Well, that's a good question. You don't really have an allergy to laser energy. So I haven't run across a contraindication. If a patient's on blood thinners because we're using a hemostatic thermal clot, often they can stay on their blood thinners if their physician is not comfortable with them coming off of it. It cuts down on bacteremia. As we said, you sampled no bacteria, so the bacteremia levels are very low. So as far as contraindications, only if you can't get them numb. I mean, if you couldn't give local anesthetic, then you could go with general. So I don't know of any contraindications for this. How much do I charge for this procedure? The magic question. My fees range from 0 to however much. It just depends on the patient's needs. Like I base it on the severity of the disease, how much is going to be involved, am I splinting, night guarding, you know, am I going to spend a lot of time with this person versus an early stage gingivitis where it's, oh, for this patient, you know, I can't give out fees over the phone, but you see how I'm trained, my front desk has me trained. Him, I would charge him like in the middle of my range. I wouldn't charge him my highest, but as I'm thinking on my feet, he does need some splinting. So I would add my splinting fee to him because he needs splinting. Yes?
I'd like to thank you so much for the surgery. And I want to ask you, do you have to place a periodontal pack?
No, you don't have to do anything like that. So all of a sudden your shelf space becomes available. No more biologics, no more peripack, no more sutures. You can put a nice flower up instead.
That's perfect. Thank you so much.
What about the recession?
Yeah, like I said, his recession, it wouldn't be a one that would lend itself to connective tissue grafting because there was so much interproximal bone loss. But the beautiful thing about this procedure is it's tissue saving. As you saw, you didn't see me degranulating anything. So his gingival margin is pretty much going to stay where it is. You're only going to get the amount of recession you would get from, say, a scaling and root planing if you had a real edematous case. So you're not removing tissue. It remodels, but you're not removing it. So recession is minimized with this procedure.
Over there.
Yes.
Did you insert the fiber, the laser, inside the whole pocket or in the superficial within 1 to 3 millimeters?
You know, it's a glass fiber, so you have to be very careful about how you insert that fiber. And again, that gets into the specific training, but basically you're not inserting that fiber like you because, oh, and I should go back and show, that's a stable clot. That clot is like glue. It's your own periacral. It's very tight and stable as far as, you don't need to use that, no. One more product you don't need.
Over here, Dr.
Thank you very much. I have a question. If the pocket is 9 millimeter, 10 millimeter, you do this, how can you control the depths you go, and if there's a calculus, how do you know you clean it out?
I know. Yeah.
Another question is, what about the later the bone region goes back?
Yes, the bone, this is known as laser-assisted regeneration. So bone regeneration can occur, especially in your vertical defects, just like with any grafting procedure. The more walls you have, the more predictable. But even in those that you may not think would come back, you can get some bone regeneration. So that's why the fact that it was started on hopeless teeth gives you encouragement. As far as knowing that you got down to the depth of a 12 millimeter pocket, that's why I like that technique of using the gauze to distend that flap a bit so that with magnification you can see further in, and with surgical suction you have the ability to do as best you can. But I understand where you're coming from as far as the possible limitation of getting a clean root surface. In the depth of a pocket 10 millimeters or more, those cases you may need to retreat at some point because you may not get the resolution that you expect. So we always say at 10 millimeters or more, you know, those are the more difficult ones to manage. But certainly give the protocol a chance to work for you, do it to the best of your abilities, and then see where you end up later with time.
Are you aware of or know of any opinion from the American Academy of Periodontics?
We have
procedure?
Yes, we do have a quote from one of their articles where they do recognize this as a minimally invasive surgical procedure that is indicated particularly in those that are medically compromised. So we do have a statement from the Academy in support, but there is an ongoing dialogue between Millennium Dental Technologies and the American Academy of Periodontology. I will say that about 30% of its membership do have this laser and do perform this protocol. Past presidents have this laser, so there are a huge number of periodontists that do see the value of offering this procedure to their patients, including members of the AAP, of which I am a member. Yes.
You showed some pretty hopeless cases at the beginning of your presentation.
Yes.
As far as contraindication is concerned, what would go into the decision that you might make, which would lead you to say, even LANAP can save this? Because that would be a contraindication.
Well, you see,
in any cases.
Yeah, that's where my husband and I get into heated arguments on. Sometimes it's not a matter of whether the tooth needs to come out, it's a matter of when is it the best time to remove the tooth. So if I can have like a live pontic, like Mish would say, keep the tooth as its own replacement until we've controlled active inflammation and we're moving into that next phase of prosthetics or implants or what have you. If you have a choice between a tooth you can splint or a flipper, what's your better option? What's the most cost-effective option? So to me, it's not whether the tooth needs to come out, it's when is the best time for it to come out. Yes?
Yes. Does the tooth have to be out of occlusion really in order for this to work 100%?
No, it doesn't have to be out of occlusion.
But is it better if it is totally out of occlusion?
If you can get there, but like that particular bite, that's never going to be out of occlusion, but if I can splint it and manage the mobility, then I've got a better shot than if I don't.
Suppose you had, like in the localized case, which you have in your literature here, where it's just one tooth.
Oh yeah, I'd take that out.
Yeah, and are you, in that case, you would fully take it out.
Yeah, then you're going to get a little
and you get an eruption.
Yes.
To help with that.
Yes, exactly.
So actually, your best results probably would be with total occlusion.
Yeah, if you can get it on some of those hopeless teeth, if you can get it out of the bite, so it's very out of trauma. Because a lot of times with those cases, it's a close problem. It's part of the problem, a significant part of the problem. So if you can manage that and get it out of occlusion, that would be great. And we do, as you see, I could still be up there grinding, but I wanted to engage you all a little more. Yes. Any other questions? Yes.
It may not be part of the LANAP protocol, but are there any studies or any advantage to putting in a chemotherapeutic agent such as Reston?
Actually, that has been looked at, and if anything, that could more interfere with the organic way the body wants to heal. But we do put patients on, like a doxycycline oral antibiotic. But no, you don't want to play around. As I said, Drs. Gregg and McCarthy kind of tried all of that too, and that really hasn't been shown to improve situations. They may have the answer to that. They've probably tried that. I would think they have and could comment on it.
Hello.
Hello.
Thank you for your presentation. Excellent presentation.
Oh, thank you.
I just want to know, coming back to the med question, not your fee, but what is the average fee only for the LANAP laser treatment, excluding the splinting? So could we know that average fee covering up the buying of the equipment? What does the company suggest?
Well, I think that the company really can't really put that. We suggest, let me put it like this, if you would say it's a scaling or group planing procedure, then you would bill it as a 4341. If you think it's an osseous surgical type case, then you could bill it as a 4260. So whatever your fee schedule currently is, you could keep that same fee schedule. You may want to bump it up a bit, like you say, there is an initial overhead expense, but when you think of increased case acceptance, you're potentially going to have more volume of patients. So the laser does pay for itself, but you really might necessarily not have to change your fee schedule. You could charge what you're already charging for the procedure and just call it what you would call it, scaling or osseous or gingival flap or distal wedge or however you want to phrase it.
Thank you very much.
You're welcome. Yes.
I don't know if my question makes sense. This is in the hospital setup.
Oh, yeah.
We don't use the LANAP method. Instead, they call it cyberknife to treat the trigeminal.
Oh, neuralgia. Okay, your question? Is there a question there?
The question is it related when we're treating trigeminal neuralgia?
I have never used it to treat trigeminal neuralgia, nor do I know of anyone that has, but I do know that there is this biostimulation where this laser can cut down on inflammation. But I personally don't know of any cases, but I wouldn't be surprised if you come by the booth that we have some information, because a lot of our clinicians are using this laser, the periolaser, for a variety of different applications. So we may have some information. The sales reps, I think, would know if there's some of their clinicians that have that experience. So I would just invite you to come by the booth after the presentation.
I have two questions.
Yes.
One is regarding, are you making a contact with the bone while doing the procedure, or just in the soft tissue sulcus?
As that final step on the diagram shows, that final pass, you are going to bone. That's why I say first do no harm. You don't want to use you don't want to use other lasers doing this, because that would not be a good idea.
And the second question is the use of products like oral kicks instead of your conventional local anesthetic block.
Oh, you mean that strong topical?
No, I mean the oral kicks that you use in the periodontal pocket.
Oh, but I mean, I'm sure you could. I don't have experience with that, so I can't. But if it works, if it gets you numb, yeah, whatever gets you numb.
Okay, thank you.
You're welcome. Yes.
Is any contraindications for pregnant patients or people with diabetes?
No, diabetes, this is like perfect. Yes. The more systemically involved situations you got, the better this is.
Thank you. What about
pregnancy? There wouldn't be a contraindication for pregnancy. Not that I know of, no.
Okay, thank you.
Yes.
What makes you decide LANAP versus regular flag surgery? What makes you decide between LANAP and vegetable surgery?
If I have a case that I know I need clinical, if I have a prosthetic case that needs crown lengthening, where I've got to, apically position some flaps and do all that sort of stuff, if I'm working along with one of our general dentists and that's the goal of the surgery, then I'm going to do an open flap osseous resective type approach. But if I'm just dealing with chronic, if I'm dealing with inflammation and infection, then this is my first step in their relationship with me when it comes to helping them manage their periodontal disease. So that's kind of how I handle that.
Do you follow up with surgery?
In certain cases, I have had to take resective approaches, but I would say that's only in about 5 to 10% of my patients. You're welcome.
Hello, doctor. Thank you for doing this.
You're welcome.
I'm questioning, when do you have this patient in your office followed up for their periodontal maintenance, and also when would you have the GP, when would you give them okay to do a crown?
Well, I would follow up with my patients usually at a 2-week post-op, and then they're kind of in maintenance at that point in time. And so, depending on, like right now, I'm letting the hygienist do most of my post-LANAP care. But initially, I did it for the first 6 months. But now, I'm very comfortable with my results. So, as far as sending the patient for a crown, again, as soon as I know that initial inflammation is best controlled, but if it's an anterior crown where the gingival margin level is so important, I might wait that 3 to 6 months. But if it's a posterior crown, I'm not as concerned. Yes?
If someone has heart problem, rheumatic fever, prophylaxis, pacemaker, all that heart issues, how about that?
This is why this is such a lovely procedure, because as long as you're okay with local anesthetic, then again the bacteremia issue is minimized. The American Heart Association has changed its guidelines, but if they do need pre-medication based on their heart condition, of course you still have to follow that. But to me, I have a certain level of confidence that that bacteremia is just a non-factor. So I'm very comfortable treating patients with heart conditions all the time. Yes?
And what is the hygiene protocol after the LANAP procedure?
Supragingival plaque removal.
At that time, and then a few months later?
Yes, until the first year. At the first year, you go back and do some good solid probings, take x-rays again, see where you're at, and then you can go, beyond where you would normally go after that first year. But first year, supragingival, a little bit in the sulcus, but you don't want to break up any new attachment or anything like that.
If the fiber is so fragile, when you do that second pass and you're going down to the bone, how are you controlling that pressure? And how often do you have fractures, and what do you do about it?
Well, that's where the training comes into play. And that's why it's nice that when you come to boot camp, you're working on a live patient, because our hands are the instructors. I'm one of the instructors. We lay our hands on yours to kind of give you a feel for that tactile feedback, and we give you specific instructions on how to handle fiber breakage, because fiber breakage can occur. So that's the type of detailed information we do give when you come in for training. You're very confident when you leave us after training with all of those problems that potentially can happen. Everybody good? Okay.
Do you use that kind of laxer in other procedures, for example, oral surgery?
Yes, like if I extract a tooth, I use that laser to create a nice stable clot. Yes, I do. I use this laser for a lot of different things. There's different settings, like I can do tissue removal, frenectomies, there's a diode setting, so there are all kinds of add-on procedures, value-added procedures that this perio laser can do, yes. You're welcome.
excuse me, what's the proper time post-operation for checking the probing?
We suggest that you wait at least 6 to 9 months, but a year is when I usually do my post-LANAP probings, 1 year. There's a guarantee that comes with the laser where if you're not satisfied, it's 6 months. So when you come for boot camp, we let you know that you can probe your cases in about 6 months. But the protocol, we really just advise about a year. But just so the new owners can feel confident that it's working well for them, 6 months can be your probing time.
I have one more question regarding relapse. And what percentage of patients have you seen relapse, if you have?
All of my patients relapse because they all have chronic periodontitis. You know, that's what I was saying. This is a management issue. So it's like with diabetes or hypertension, as the therapist, you just have to understand that there's no end point, really. You just support them as they present to you. So I won't say they all relapse, but I'm always looking for them to relapse. You know, I'm always checking them to see if they're stable or not, because I'm kind of expecting that activity to come back, because I know they're in that category of a chronic condition.
And in that case, would you vary your fee schedule?
Yes. Yes, like I've got some people that I just am constantly treating. So yes, my fee schedule does vary, definitely. Yeah. So that's the beauty of this, because once the laser's paid for, the overhead is just the fiber. So your fees can really, you're not paying for the end-of-gain or the bone graft material or all of that. So it's very cost-effective, very cost-effective in managing chronic conditions.
Right here.
How long is the boot camp?
3 days. 3 days of serious training, and then 6 months later, 1 day, and then another 6 months, another day. So a total of 5 days throughout that year, but those first 3 days are the most intense. That's why we call it boot camp. Say that again. The cost? When you come by the booth, we can quote you some fees, because they're meeting deals and all kinds of things that are going on. So I don't really have the cost in my head, but the sales reps do.
Locations?
Yeah, they train here in New York, yes, in Long Island and in Buffalo, and in California. Yes.
Can a hygienist take this course?
There is a course for the hygienist, but it's not for LANAP. There's a hygiene setting that this laser, that the perio lays can be used, and there is a course for hygienists, because that maintenance phase is so crucial. And so there is a course for the hygienist, but no, not for this. This LANAP procedure is considered a surgical procedure in certain situations, so it's not for the hygienist.
Thank you.
You're welcome.
In essence, this is really an adjunct to scaling and replaning. It's really an adjunct in addition to scaling and replaning.
If you choose to look at it like that, then that's fine. To me, it's just therapy. I look at it as all therapeutic. I look at it as surgery sometimes. Sometimes I do look at it as just a glorified scaling and root planing. In a type 4 case, I'm not going to look at it as scaling and root planing. I'm going to look at it as I'm getting down and going deep. So this is not scaling and root planing. So the case determines what I call it. So that's why I call it periodontal therapy.
Any more questions?
All right. Yeah.
Let's hear it for Dr. McCullom. What a phenomenal presentation.
Thank you.
The information and assistant everyone on stage today. Not easy to go through right in front of all these people to make things work out so beautifully.
Thank you.
Great presentation, great procedure. Don't forget, if you're interested, 3834 Millennium Dental Technologies will be the sponsoring booth of today. We also thank Zycam, FutureNet. We thank